Hey guys, welcome back to an episode of meded.pearls, where we provide pearls for the steps, boards, and wards. Here's your pearl for the day. Welcome back to another episode, and today we'll be talking about HRS, or hepatorenal syndrome. So the idea is that the organs in the body crosstalk with each other. So if there's an issue with the liver, it will lead to a downstream effect on the kidney. Thus, the kidney issue or kidney disease is due to the underlying liver disease. Now, when we talk about HRS, we have two types. We have HRS type 1 and HRS type 2. HRS type 1 can be considered where there's a sudden and rapid onset of renal disease due to liver disease, whereas HRS type 2 is a more gradual onset of liver disease causing the kidney disease. Now, it's important to understand that it's a diagnosis of exclusion. It is a diagnosis of exclusion. So what does that mean? We want to look for clues that point to other etiologies such as pre-renal AKI and try to rule out other disease processes before coming to a diagnosis of HRS. The way that we do a diagnosis of HRS is that there's a clinical history, liver cirrhosis, absence of shock, absence of nephrotoxic agents, absence of any other underlying kidney disease etiologies. There's no improvement in symptoms after giving volume and holding diuretics. We can often see ascites in the physical exam, sometimes tense ascites. Now, how do we end up with HRS? What's the underlying pathophysiology? So there's a disruption in the liver parenchyma, fibrosis that ensues due to this liver cirrhosis that causes a portal hypertension to develop. And in the doing so of this portal hypertension and fibrosis, there's a release of cytokines and markers such as nitric oxide. Now, this nitric oxide is important because it leads to an arterial and splanchnic vasodilation. So when all the vasculature in the liver has been vasodilated because of nitric oxide, the effective arterial blood volume, in essence, decreases. Because of that, you end up having a decrease of renal blood flow to the kidney, thereby leading to kidney disease. Now, how do we treat or approach a patient with HRS? One is that we are going to go ahead and withhold diuretics, and we're going to give some volume in the form of albumin. Now, you want to give 1 gram per kg body weight of albumin for 48 to 72 hours and assess the kidney function during this time. If there is no improvement, then you want to go towards a vasoconstricted agent. Now, one of the treatment therapies that are given for HRS is terlipressin, which is a vasoconstrictive agent that acts on the alpha-1 receptors, and the biggest side effect that has been seen with terlipressin is respiratory failure and volume overload. Now, in settings where terlipressin may not be available, we can go for pressors such as levofed, i.e. norepinephrine, or we can also go for midodrine and octreotide. However, more favor is placed towards pressors such as levofed or for vasoconstrictive agents such as terlipressin. Definitive treatment for these patients would be liver transplant, albeit we can offer renal replacement therapy, but it's more so of a bridging therapy while they go for a transplant. And that's your pearl for the day. For more pearls like these, please continue to like, subscribe, and share. Thanks.